Welcome, everyone, to the International Childbirth Initiative 12 Step to Safe and Respectful Mother-Baby-Family Maternity Care webinar series. My name is Michelle Scartharian. I'm the Executive Director of the International Childbirth Initiative. ICI is an implementation and quality improvement process which strives to achieve the 12 steps to safe and respectful mother-baby-family maternity care through a self-evaluation and reflection process conducted at the facility level. ICI also provides a global resource network of facilities striving to share their learning and improve the provision of care. ICI was created through the joint effort of the International Federation of Gynecology and Obstetrics and the International Mother-Baby Childbirth Organization. It includes actually more than 30 partner organizations and continues to grow every day. And we're open to all birthing facilities who are willing to commit to delivering safe and respectful mother-baby-family maternity care. I'm thrilled to introduce today's speakers. Our first presenter is Dr. Hakan Koker. He is an obstetrician and gynecologist, a Lamaze certified childbirth educator, and a co-founder of the Istanbul Birth Academy, where they run the Birth with No Regrets education program, which educates both families and healthcare providers, doctors, nurses, midwives, in respecting women's rights during childbirth. Our second presenter is Dr. Edson Borges de Souza of Sofia Feldman Hospital in Brazil. Sofia Feldman is a non-governmental philanthropic institution with 90 maternity beds and a 45-bed neonatal ICU. They are maintained exclusively using public resources, and they are a member of the Stork Network. Dr. Borges de Souza is an obstetrician and gynecologist who is an advisor for the Health Ministry of Brazil, as well as an advisor for PAHO. He is an instructor of advanced life support and obstetrics and designing an evidence-based antenatal care course for primary healthcare professionals. Today's presentation is on step 7, avoiding potentially harmful procedures and practices that have insufficient evidence of benefit to outweigh risk for routine or frequent use in normal pregnancy, labor, birth, and the postpartum and neonatal period. I would like to acknowledge that this presentation was developed with Mary Sagady Leslie and Layla Sherry. And with that, I'm very pleased to hand this over to Dr. Hakan Koker.
Thank you, Michelle. It's an honor to be here in this ICI presentation. And this presentation will be about the 7th step of ICI. Yes, we can start, Michelle. Changing the slides. Thank you. Step 7 is about interventions, which is very important in labor and birth. It says we should stop harmful procedures without any evidence. And in other names, it says you shouldn't do it routinely and frequently. I'm an obstetrician, so I will start with a different way of look here. I know most of the advocates will think I'm crazy here, but I love interventions, to tell the truth. Because what's an intervention? It's an action taken by a midwife or a doctor for the wellness of the baby or the mother, with the, of course, mother's informed consent, which means you do something good for them. For example, if she's too weak because she's vomiting during labor, if you put an IV, she feels great. I mean, it's a comfort for her. Or if the heartbeat goes down suddenly at the end of the birth, and if you do vacuum extraction, you save a baby. So they are meaning something good for you. Also, I'm a childbirth educator, and I teach this in the childbirth classes, that all interventions are invented for a good reason. Yes, it sounds nice, but there is, of course, a but. But if they are not done routinely and frequently with no reason, of course. If you do them routinely, then you definitely can harm the birth physiology, because the birth physiology is so complex that whatever you do with no reason, you can spoil it. There is no intervention for birth which is totally positive and beneficial when it's not done, it's done routinely and it's practiced routinely. So let's start step 7 again. And Let's talk about two fundamentals in step 7. The first fundamental is all the interventions should be evidence-based. And the second fundamental is it should be all not done routinely. Here, I want to mention something before we go. This session is discussed here is the management of women experiencing a normal birth who are at low risk and have no indications of a high-risk pregnancy. So we are not talking about high-risk pregnancy. We are talking about women here who have no problem, who have no risks at all at the time of labor and birth. Some interventions here are never recommended, and others are recommended only if the woman is high risk. Yes, Michelle? And of course, it's a big subject and there are many things to talk about. So you can find most of the evidence in this WHO labor care guide and also in the 2018 WHO references for the good birth practices. And at the end of the slides, you can also find the list of the other literature you can apply for later, and this will be for your use for after the session. Yes, these are the fundamentals. You can have evidence. It should be evidence-based, all of these interventions, plus also, which is very important, interventions should only be used if it's the mother's choice, after she has been provided with all necessary information about risks and benefits. Yeah. I love this slide. This is a very important slide, I think. Here, we're talking about the benefits and harms. Of course, in labor and birth, in other health problems, there will be interventions. So it says, if there is evidence of benefit, then it should be recommended to the family. And if there is evidence of harm, yes, it should be recommendation against it. So, but there is a very important thing here. If there is no benefit or harm proved by the evidence, then the mother's preferences should be respected all through labor and birth, which is important. It sounds easy here, to tell the truth, but it's not an easy step to achieve, to tell the truth, because especially in countries where doctors are responsible for everything in labor and birth, but not supported by laws and the system. Because even though at first it seems like a mother's choice, when things go wrong, there is a potential risk of the family suing the doctor or who is responsible there. So the doctor is the person to prove that not only she was informed, but also she understood everything. So it's a gentle line for the doctor, either to support the mother for potential risks of being sued or to protect himself and decline the mother's choice. This is the practice in most of the low-profit countries. So I know this is the right, and this is kind of a symbol of humanistic approach to this slide. But it's not easy to apply all the time. So I also understand my colleagues when they cannot full-heartedly follow this sometimes. Also, let's talk about the decision-making. We are talking about two kinds of decision-making. One is informed decision-making and one is the shared decision-making. In informed decision-making, you become a team and share the decision and responsibility with the family. But also you put everything there and you are the doctor or the midwife is responsible for knowing the most current recommendations and supporting the evidence. But here, the mother is in the center of decision. After you tell them about everything, then you give them space to decide. But shared decision making is a bit different. Suggests that the provider has a role in decision making. ICI doesn't recommend using the term shared decision making because it takes power away from the person giving birth. Only the person giving birth can make a decision about the baby. Respecting this can reduce birth trauma or regrets in birth. This is the picture, and if you can note this, and you can find this everywhere online, and the PDF is free for everybody, and you'll find all the evidence links and evidence papers there when you need it. Okay, these are the most of the evidence interventions, and we'll talk about them one by one, so I don't want to list them all through. Let's start with Enema. Enema, is one of the routine, was and still, unfortunately, routine interventions of birth. But evidence show that there is no benefit for the baby or the mother. So at the moment, there is no discussion that routine enema has no benefit for mother and baby unless it's the mother's choice. Yes, I know it's still routine in some facilities. They still think it reduces postpartum infection, but unfortunately, the evidence says that it's not true. It doesn't change anything. So either you have enema or not, it doesn't make any difference. So it must be the choice of the mother to accept it or to decline it. This is another thing, sweeping of the membranes. It seems like it's becoming more routine and routine in most facilities. But let's look at the evidence about it. It says membrane sweeping, current evidence suggests that it does not necessarily lead to unassisted vaginal birth. Yes, there are positive effects on spontaneous onset of labor. But still, it's a question. I mean, if you sweep the membranes and the birth starts, let's say, is that a spontaneous birth? Spontaneity means baby decides he or she is ready. And together with the mother, they together, like a team, give a start for a birth. So if you make an intervention, it doesn't make that you start something spontaneously. So this is an intervention which spoils the spontaneity of birth. So yes, it might start the birth, but it's not still suggested to be done routinely, especially without the knowledge of the mother. That's the worst thing. I mean, you should always get the informed consent of the mother for the positive and negative effects of sweeping the membranes. And let's talk now. This is not the easy point, yeah? This is episiotomy. Episiotomy is discussed all over the world. When I was a young assistant, I was a young person, I was told that you should do episiotomy for every first-time mothers. So that's how we were raised, and that's how we did. I did this for nearly 19 years. Then I started reading and going to childbirth education classes and reading the advocates for natural births and everything. They said, okay, you don't need to do it. When I looked at the evidence, it was there. I don't know why I never read that before. After 19 years of my practice, I started lowering the episiotomy rates because the evidence says that routine episiotomy does not result in a reduction in perineal or vaginal trauma, and it requires sutures and can result in severe pain, bleeding, and infection. And refraining from using episiotomy is associated with a reduction in severe trauma to the perineal tissue, and there are no benefits of routine episiotomy for the baby. It doesn't say don't do episiotomy. It says don't do routine episiotomy. So because it doesn't make any benefit, it doesn't have any benefit for the baby or the mother. So nowadays, evidence says that episiotomy should never be routine, and only for real good reasons you can do it. And whenever you do it, you need to have the informed consent of the mother, of course. Um, uh, Here, I can hear you. I mean, probably there are people listening to us who say, okay, we do it every day and we are scared about the third and fourth degree tears. I give you a secret. Uh, Without routine episiotomy, they do not go up. And mostly we are the reason for those tears with the crystallar or forced accelerated pushing. If we as health professionals can slow down, then we see less tears. And the critical point for less episiotomy is the respect for labor and pushing time, which is very highly mentioned in the WHO 2018 recommendations. So when you slow down, and especially when you slow down the mother, you have less episiotomy, and you see the perineum can relax easily, and you will even see less tears. And what about the third and fourth degree? If you slow down, probably you won't see as many as you see now, even with episiotomy. So episiotomy shouldn't be used routine, and it's one of the most concerns of mother, because after birth, mothers say that this is the most negative effect. The episiotomy and perineal traumas, they are more concerned about that. Otherwise, they don't have much problem about birth effects after the birth. Okay. Yes, this is another thing. Frequent vaginal exams. I was also raised in a place where shifts were changing, and all the people before the shifts were examining the mother, and the ones who are getting the new shift examining the mother again, not trusting each other. I think this is a bit, it's like a horror story for me now, because vaginal exams are recommended now with evidence at 4-hour intervals. And even though you can have less intervals even. So I will say when needed, but not less than 4-hour intervals if you have a good specific reason to examine the lady. And of course, every time, not the first time, every time you need an examination, you should have obtain the consent of the mother with respect and dignity. So vaginal exams, women never like them, and they will never like them. So in evidence, you should have them at least in 4-hour intervals unless there is a real problem. Okay. And the last one with me, before Edson speaking, and will be about food and water. I must say that, again, I think I was raised in I did my specialization in somewhere where we did all the routine interventions. And now I do none of them. And did anything change with the mother and the baby? Yes, but in a positive way, not in a negative way. So for all my colleagues and midwives and everybody, routine interventions are really harmful for mother and the baby, and it doesn't make any benefit. This is the same. I mean, we hardly gave any food or water, and they were really thirsty, and we were giving drips sometimes, little one, but I don't know why we did it. And all the evidence say now, even 2019, 2020, from anesthetists from everywhere it comes, it is the first right of the mother to have enough food and water during labor, unless there is real health problem. So it doesn't make any difference. Of course, people will say, okay, when there is any emergent cesarean section, the evidence says that the negative effects of having food or not having food is not different with the new anesthesia techniques and everything. So every facility should do their best to apply enough food and water for the woman. And I think this shouldn't be any problem. And it's not any problem in many facilities nowadays. And once you do it, you will see that mothers and babies will be much happy. You'll have less problems with the babies. Okay, Edson, I think my turn is over. You can continue with the other interventions.
Hello, I'm very pleased to be here, and I'm very grateful to my colleagues, and I'm very proud of being part of this team. I will be talking about some interventions that became standard of care during the last century all over the world. And one of them is keeping mother immobilized. We know that women should not be immobilized during the first and second stage of labor, because this has no benefits for the mother, and even this can be harmful. Giving birth on their backs in what we know as supine positions can be very painful, uncomfortable, and even it can delay the progress of labor. And we have already a lot of evidences showing that women who stay upright or walk around were in the first stage of labor for approximately 1 hour and 20 minutes less than those that were in bed. This means that women who walk around can have a faster labor, even in the first and for the second stage of labor. And mothers who were mobile rather than lying in bed faced more benefits, both on reduction in the risk of having a C-section birth and less use of epidural for pain relief, and a less chance of baby being admitted to neonatal unit. Then, because of that, WHO Labor Care Guide supports upright positions and charting of the woman's position hourly. And this is true for the first stage of labor, and this is true for the second stage of labor as well. Hello. Fundal pressure, this is intervention that is very used all around the world. In Brazil, my country, investigation showed that more than 40% of women had a fundal pressure during labor. And why people do that? One of the most common reasons is that people believe it's necessary to accelerate birth during second period of labor. But there is no evidence that this intervention made a difference to mothers delivering vaginally within a given amount of time, because the time taken to give birth was not affected by manual fundal pressure. And there is insufficient evidence from RCTs to support this technique or this intervention as an effective way to shorten labor or avoid C-section. And I would add two very important information. Indeed, most of the time, there is no need to accelerate birth. If we know the physiology, the physiological, the normal physiological birth, we will believe in that. But this is a very strong belief. People really believe labor should be accelerated. And if we really need to accelerate birth, safest options are preferred, even a C-section. If we really have to accelerate birth, and if birth is not imminent, and if if to wait is not safe, then we have to adopt another safest option, including C-section or even an operatory vaginal birth. Hello? Immediate cord clamping is not, it's an intervention that is not recommended. Clamping the umbilical cord early after delivery was previously a standard practice to allow for the baby to be quickly moved into care from specialists. Because this is another strong belief, some people believe that we have to take the baby, the newborn, and to put them in a warming cup. And we believe that this is the safest option to maintain the newborn temperatures. But this is not true. The baby can stay, and this is another very important thing. The baby should stay skin to skin with her mother. And delaying clamping of the umbilical cord for 3 or more minutes may allow for the baby to more easily adjust to breathing air. And this allows for continued blood flow between the mother and baby, easing the baby's transition. And this will diminish the risk of the baby having anemia through their first year of age. For delayed cord clamping, the study found that it was likely that fewer babies died before being discharged. And this has many reasons. One of them is a less risk of anemia. The study also found that it probably reduced death risk for preterm babies, and current evidence supports not clamping the cord before 30 seconds for preterm babies. Then this means we can do that even for preterm babies, and even if we have a C-section, we can delay cord clamping even during a C-section, unless there is no hemorrhage, but usually we can delay it. And there are certain practices that can be harmful for low-risk women, yet helpful or essential in emergency situations or even certain high-risk cases, and thus should only be used when medically indicated. And this kind of interventions include medical induction or augmentation of labor. Of course, we cannot abolish this kind of interventions. They are very beneficial in some cases, as we have been high risk or some emergency situations. Intravenous fluids, we should never do that in a routinely way, because if we do that in a routinely way, this will invite another interventions. This is what we call the cascade of interventions. One intervention calls a second one, and so on. Continuous electronic fetal monitoring, insertion of a bladder catheter, a C-section. I love this intervention too. It can be mother or baby saving, and this is a very important, I believe this is one of the most important achievements of obstetrics in 20th century. C-section became a very safe intervention, but even after, even being a very safe intervention, it is still harm. It can still do harm if we don't have a clear medical indication. The forceps and vacuum extraction too, it can be life-saving. Manual exploration of the uterus only if we have a placenta that was not spontaneous delivery. And suctioning of the newborn. We should never suction in a routine way. When we suction a baby, this is not inoffensive technique. We can delay the time necessary for the baby to have a good saturation index. And a C-section too, it's repeated here. Okay, I've already talked about it. Yes, we have to learn to keep calm and first of all, do not harm. This is a very anxious knowledge. First, do not harm. This is one of the most important things in medicine. And every mother baby should be protected from unnecessary and potentially harmful interventions, practices, and procedures, and from both overuse and underuse of medical technology. We don't want to abolish technology. We just want to use it in a right and precise way. Well, quality of care. Caregivers are individually and collectively responsible to the mother, baby, family, community, and healthcare system for the quality of care provision. The needs of the mother, baby, family must take precedence over the needs of caregivers and institutions. We as caregivers are not more important than mother and baby family. Their interests are above our own interests. This is a very important thing. And all women, including those with complications, should receive full, accurate, and unbiased information based on best evidence on potential harms and benefits of obstetric and neonatal procedures and alternatives, so that they can make informed decisions about their care and their baby's care. I would like to comment this slide. Sometimes we fear women should not do good decisions, but this is not true. When we inform them about risks and benefits, usually, or they never will do bad decisions. There is a rationality. Even when they are they are strongly committed to their own wills. They accept decisions. They accept our informations. This is usually what happens in maternities that are already used to respect and to talk about informed and shared decisions during labor. These are the quality indicators of our hospital in Brazil, Sofia Feldman Hospital. And as you can see, since 2010, we have around 10,000 childbirths each year, and we are the largest maternity hospital in Brazil. And we have maintained a C-section rate. Our C-section rate indeed increased during this time. We reached 28% in 2020. We have our perineal tears rate increased too. We don't know. We have to check if there was a real increase or if our team improved recognition of this problem during labor. I don't have this information, we have to check it, because at the same time, our episiotomy rate decreased too much. Our rate of operative vaginal birth remained stable during this time. And more than 80% of deliveries assisted in our hospital are assisted by midwives. And around 40% of deliveries are high risk. And this means, I think this is an important thing to say, high risk pregnancies are not always are a high risk labor and childbirth. And even when the women have a high risk pregnancy, they can have a humanized and an evidence-based care during labor. And not always they need interventions too. Of course, usually we need we have to do some interventions, and is like induction of labor and even C-sections. But most of the time we can do it in a humanized and in a way that share information and in a shared, and we can share decision too. Okay, next. And here we have our C-section rates according Robson groups 1 to 5. And we can see that in groups 1 to 4, we have maintained a low rate of C-sections as in group 3 and 4. And group 2 and 4 in our hospital usually are induction of labor. And we can see here that even for induction of labor, we have C-section rates. They are according to what literature says. Literature says this is possible to have a success rate of around 70 to 80% in induction of labor. The most important thing here is to have a good criteria for the diagnosis of failed induction. And if we have good criteria and if we apply it, we can have this kind of success in inducted labor. And the group 5 in Brazil, as you know, we have more than 50% of C-section rates, and this implies, and as we are inserted in this environment, then we have many women that already had a C-section rate. They opt or they choose to have a second C-section rate, and these have an impact on our C-section rates as a whole. Okay. Next. Facility or practice rates of procedures are within acceptable international range and are made available to assessors. Different ranges will be expected for referral practices and referring facilities. Yes, there are different situations, and as we have different situations, we need to different ranges. And benchmarking with other services is available. We have to exchange information. We have to help each other, because this is a big change in practices, and in many places in the world, I think there is a generational gap. Sometimes in countries like Brazil, which has a very high C-section rates, sometimes the junior doctors and the new professionals, midwives, they have not persons that could teach them this new model of care in obstetrics. And then we have to give our hands, we have to help each other to exchange information in order we can advance. Women's interviews and questionnaires show that they are informed about the reasons for suggested interventions or procedures, and their consent is sought. Yes, first, do not harm. Appropriate, non-routine, evidence-based use of interventions. The message is not to abolish interventions, but use it in a right way and ensure quality of care through a mother-baby family focus of care, and always inform families.
Edson and Hakan, thank you so much for this presentation. I think that this is very, you did a fantastic job. It's a lot of information to cover and to share your personal experiences of what you have seen in your practice. I want to also say thank you to Mary Sagadi-Leslie from IMDCO, who started this presentation for us, and also Leila Shere, who was our research assistant in gathering all of this evidence that we will show here at the end. We have a lot of evidence that is included in this presentation, and so the slides will be available if people need to go back and they want to look up, if you want to look up a specific study to get a good understanding. But I'm going to pull us out of the presentation now so we can discuss a little more. I'd like to begin by talking about, I think both of you, Edson and Hakan, have experiences of having to transform your practice through the years, and you touched on it, and then sharing this information with others. And how do you create change, right, systematically? So Hakan, I wanted to let you speak first about your experience in educating providers, and what have you had to do, and what are your recommendations?
Thank you, Michelle. In Istanbul, Turkey, we also have a place called Istanbul Birth Academy, and there we do childbirth educators education plus doula education. And there we have students from all professions. It's like obstetricians come sitting next to midwives, nurses, psychologists, and doulas together. And there it's still, and I can understand it because how we learned everything, people come, the obstetricians coming to us with really high rates of episiotomy routine, with high rates of many interventions and crystallers and everything. So then in the first lessons, they go really shocked with the numbers we share. And they say, how can we do this? I mean, we are scared. I mean, this will harm. I mean, we can't do without episiotomy. We can't do without all these interventions. They don't push enough. They don't do this. They don't do that. Blah, 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 blah. What I say is start with one thing first. I mean, first, I'd say to the doctors, this is an education of folding your arms together and waiting, like midwives do, like they need midwives. So I say, if you wait and respect the physiology, they will give birth. And if you wait, yes, you will, after 2 hours maybe, you will see the perineum relaxes and getting really bigger enough to let the head pass through that. So I say, just start with the second time moms and third time moms, maybe whatever you like. So once they start putting their hands back, and once they start respecting the time, in nearly 6 months' time, their 90% episiotomy rate go down to at least 30%. And in the next year, it starts going down. It's a declining bit. So they need an example, to tell the truth. So how we did it is being an example and talking about it and saying that this is possible. And once they talk to each other, they also encourage each other. They say, I did it and I see less problems in birth. I mean, I used to see many declines in the heartbeats and blah, blah, and many problems and tears. And they say, now I don't see them. I just wait and let them give birth. So in 1 year time, they can totally change their practice. So the magical thing I will say is to start it and trust the evidence. because it's there. I mean, if it's laparoscopy, if it is drugs, if it is any screening test, we follow the next day the evidence, whatever comes new. But why don't we see the evidence there for birth? Because it's simple. It's so simple, but we never want to see it. So it's written there. We just don't want to see it because we're scared. I understand them. They are scared that something will go wrong. So what I would say is start with simple things, and one by one at a time, one woman at once, then they will see that it's easy. That's birth. I mean, then they will feel the passion why they become an obstetrician or a midwife. Then that's much fun. That's what I experience with my students.
That's amazing, actually.
But I found it harder with the institutions, and that's what Edson. I admire him now because I can deal with one obstetrician, but with an institutional thing, that's also my question. How can you do it?
So Edson, do you want to add to that?
Yes, I strongly agree with Hakan. I see the thing in a way. I think the most difficult, the more people think it's difficult because the problem is that obstetricians don't know nothing about normality anymore. And if they don't want what normality is, then they act as if everything was abnormal, and they act as as a prevention. They do interventions to prevent problems, and I think the great challenge in teaching obstetrics is we have to understand normality. But the problem in countries like Brazil with a very high rate, and this was appointed by a researcher here in Brazil around 20 years ago. 20 years ago, we had a C-section rate of about 30%. And in that time, this researcher said, with a so high rate of C-section, I believe that people, the junior doctors, are not exposed anymore to learning environments. And he said that 20 years ago when we had only, I don't know if this is only, when we had 30% of a C-section rate. And now we have 55. If that was true 20 years ago, this is even more. Then the challenge is to put junior doctors and midwives that are in their training times to know about normality. How we have doing this in our hospital, because we are a school hospital. Well, we usually assign a doctor in their first year training. You have to care of this woman from beginning until the end of labor. You have to stay beside, we have to stay at the side of this woman all the time. No matter what happens, we have to stay here all the time. This is a challenge in very busy hospitals, when we have many women having their childbirth, because our human resources sometimes are limited, and we have hospitals have to use the workforce of the trainees, and this is a limitation. But we have to do it. We have to teach them what normality is, because there will be only possible to have a good judgment about abnormality if they want what normality is. I think there is no secret about that. If we have to face this challenge, And beyond of that, to organize the workforce of trainee years, we have to introduce the new standard of normality, because Friedman curve, for example, that it's yet used all over our country, and it's not useful anymore. And I think we have to introduce new standard of normality, and to expose and to put trainees in this kind of environment. I think this is the last thing. Midwives are very important to do this, because midwives are, I think they are specialists in normality. And we need is normality specialists. I don't know if this is the right name, but they are specialists. They know what normality is, and doctors don't know. Doctors don't know what normality is, and they always act as if, because they don't know what normality is. And if we work in the limits, in the frontier of normalities, on the abnormality variations, because normality has variations. Normality is not always the same. Yes, I think these are my what I had to say.
Thank you. I think I really appreciate that you both touched on similar strategies, and also the importance of midwives and midwifery care, which we cover in other steps, but I like that you were able to tie how that impacts step 7 in particular. And both of you during your presentation touched on fear and provider bias and how that plays a role, and the importance, I think, of understanding the difference between keeping the provider focused on the evidence and recognizing that bias or that fear-based decision-making, because what I'm hearing from you is that providers will very often want to push women towards a certain decision for an intervention out of fear of what is the worst case scenario. And what we're trying to encourage is the understanding that following the evidence should lead to positive outcomes, and that fear-based decision-making is never, I think, the path we want to go down. But is that, so both of you have seen that though, that when you follow this evidence, you're seeing these positive outcomes.
Yes, definitely. I agree with you. And the fear of the obstetricians, and in some places, maybe the midwives, I'm not sure about that, because in my country, obstetricians are like the gods of the obstetrics, And midwives usually do what they tell, what the doctors tell, because of these private hospitals now everywhere. Nearly half of the mothers are giving birth in private hospitals, so that's the reason. And private hospital means more cesareans and more interventions, definitely. And when I talk to my colleagues all around Turkey, and even maybe the world, the thing they say that if they change the laws and protect us, being responsible for anything going wrong in birth, then all interventions will go down and all cesarean rates will go down. They all agree about this. But at the moment, the practice is whenever something goes wrong and they're sued, they're alone. So after one court, they say, okay, birth is enough for me. I will do what to protect myself and my family. That's why intervention is going up and cesarean rates are going up. So we have to find a way in such countries like mine, and this is probably 80% of the countries, I guess. And we have to find a way to settle down this malpractice problem for the doctor, then everything will be okay. Plus, of course, a midwifery-led units will have less interventions and more satisfaction with the mother. And to add, one last thing to Edson, I like the idea of the first-time year students following the mother from the first minute to the last minute. I like that. And in our education, we ask them at least for 1 month, all midwives and obstetricians, if possible, to become a doula in one of the births of the mothers. They teach childbirth education as a stage. So once they go there in the room, maybe in the first time in their life, they stay in the room until labor is finished and birth is finished. First time, they never do that again. And then they realize how hard it is and some midwives say to me, I like it very much. And it makes me to go to tears even. I am 25 years old, midwife, 25 years experience. I noticed that I never saw the baby, or I never saw the mother. I was checking the bleeding. I was checking this and that. When I worked like a doula, I realized that there's a woman and the baby being connected and lovely thing, everything is going, and it's more fun, they say. So I like that we are from different parts of the world doing the same thing in the humanistic manners for our students. I like the idea. Thank you.
Yes, this is an idea. Sometimes the students don't like it. They think that they need to assist a big number of childbirths. I don't know if this is the right way. They sometimes they stay the whole day with just one woman, and they think they should have seen 2 or 3 or 4 childbirths, but this is not true, because what we have to teach students is to value each one of the moments during childbirth, and to recognize the signs, they recognize and to manage pain and to manage anxieties, both of the mother and of the family, and to give information. I think this is to care for the childbirth, and this is what we have to teach. Not only to teach to make a episiotomy or to hear the fetal heart rate, and this is not the most important thing. But another thing I would like to say, according to what Hakan said, people, professionals, obstetricians fear results and fear bad outcomes. And they fear, what they fear, indeed, I think they fear risk. Risk is a problem. But we know risk is not a real thing. Risk, the definition of risk, is something that can happen in the future. It can happen or it cannot happen. But if it can happen, this usually press the obstetrician to do something. Then I think we managed to, in a wrong way, the definition of risk. Risk is a possibility, is not a reality. And then I think this is another thing we have to teach the students. It's how to manage risk. And we have to understand the risk. And there is a study, I read this study, this paper some years ago. The researcher saw that when they talked about risk, both to professionals and to the woman, both professionals and women were more there was a trend to do interventions. Always when we talk about risk, it doesn't matter if it's a risk of 0.1% of having a uterine rupture, for example. But if you tell the word risk, then this moved patients and obstetricians and professionals to do something. And they ignore that interventions, they have their own risks that can increase the original or basic risks. Then I think the other thing we have to manage is how to manage risk and how to talk about risk both to patients and both and to the professionals. And this is, I think, the second point we have been discussing here, the management of risk.
I agree with you, Edson. And one last thing for me to add to Edson is because we changed the culture because of the talking about risks. That's why interventions go up. So when I asked to the low risk woman in my class, childbirth education, okay, you can have a guarantee in birth. They say yes. And you're a low risk woman. Okay. Do you know your risks in birth? And surprisingly, they say between 10 to 50% about losing their babies in birth. So that's what in their mind. We changed the birth culture. So now we are trying to change it back to positive, which is not easy. So I think childbirth education classes should be in more important position about changing the birthing experiences in a positive way. Thank you.
Agreed. Thank you so much to both of you. I'm sorry that we're out of time because I feel like we could probably continue for another hour with your experience and on this topic. So I want to thank you both for joining us today and giving this fantastic presentation. I know it's going to benefit so many of our sites and those who get to view it. I want to thank everyone who's joined us today to watch this session. I hope that they will go on to watch the other 12-step episodes in this series. We are up to step 7 now, so we are a good way through our webinar series. I would like to thank both of you again, and I hope that if anyone has questions about these topics, that they go ahead and go to the resources for this session, or please send us an email and we can continue this discussion offline. But I want to thank everyone again. I hope you have a wonderful day, and we will see you soon.
Thank you.
Okay, thank you very much.
And we will share the links, Hakan, also to the Istanbul Birth Academy, as well as to the Sofia Feldman Hospital.
Thank you. Hakan.